Okay, and it is noon, so let's go ahead and get started. Hello, everyone. Thank you so much for being here today. My name is Joanna Smith. I'm a behavioral health consultant, and I am with the Michigan Opioid Collaborative. And today we're having our perinatal mini-series, which is a collaborative effort between the Michigan Opioid Collaborative and MC3. This is part 2 of our 4-part series. This is going to be on medications for opioid use disorder in perinatal care. We do have a lot of information to get through today, and we're excited to have you. But before we do get started, just a couple things to keep in mind. If you could please keep yourself on mute, that would be great. We will have some time at the end for Q&A. So please, at that time, feel free to unmute yourself and ask questions then, or you could throw your questions into the chat. Please go ahead, if you haven't already, sign into the chat with your name, your email address, and the organization that you're with. Your local behavioral health consultant will be following up with you afterwards with slides from today's presentation, as well as other information about MOC and other upcoming events that we have. So, like I said, this is a collaborative effort between MOC and MC3, as well as our Great Moms Model of Care, the Great Moms Model of Care. And this is just a listing of all the folks that are involved in each of these teams and everybody that was involved in the planning of this process. So like I said, I have your regional behavioral health consultant listed here on this page. These slides will get sent out to everybody afterwards. So if you have any questions, feel free to follow up with your local behavioral health consultant. And we're going to go ahead and do a brief overview of what the Michigan Opioid Collaborative provides. So I'm going to go ahead and throw it over to Megan for this.
Thank you so much, Joanna. Thanks everyone for joining us today this afternoon. Just a brief description of what we do here at the Michigan Opioid Collaborative. We are an interdisciplinary team that supports providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid use disorder and other substance use disorder throughout Michigan. MOC is grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer free same-day consultation services to help provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case questions related to treatment and management of substance use disorders. MOC offers quarterly introduction to buprenorphine trainings, as well as webinars on a variety of educational topics such as addiction, stigma, and substance use topics. We have a hepatologist on our team who offers Hep C treatment consultation within 48 hours, facilitates a biweekly case consultation webinar to review cases with providers, and has developed a 3-part webinar series on HCV treatment. We have created many toolkits for providers to have more resources when treating patients with multiple SUDs, and those can be found on our website. The Michigan Opioid Collaborative also has behavioral health consultants around the state that are happy to help facilitate trainings, answer questions, troubleshoot with technical assistance, and be able to provide an extra support to your organization or your community. Please take a look at our website for events and contact information, and we hope that you will enjoy our second part of 4 for today's webinar. Joanna?
Thanks so much, Megan. So I'm going to go ahead and stop sharing my screen so that we can go ahead and get the presentation started, and I'll hand it over to Dr. Kara Poland, who will be going over MOUD and perinatal care today.
I have like 12,000 things open on my computer, so I just shared my whole screen. Joanna, did we need to have anybody from MC3 give an introduction to MC3 while we're doing introductions?
I just gave an overview of all the MC3 folks, so okay. I think you can go ahead and get started.
Sorry, maybe I missed that. I apologize. I apologize because I was a few minutes late jumping from meeting to meeting. Thank you so much, everyone, for joining this session. I hope people were able to join the previous session that Nancy did last month. As Joanna already mentioned, there will be 2 more sessions coming out over the next 2 months to kind of continue this this journey together as we look at opioid use disorders, and mental health in pregnancy. Just as a reminder for folks and for anybody who wasn't here last time, Nancy did a trauma-informed care and a trauma background discussion for this group last month, and I believe that is going to eventually be posted on the MOC website. Otherwise, I'm sure we can share a PDF of the slides for folks that are interested. I nor any of my family members have any relevant financial disclosures. I know I'm kind of preaching to the choir for a lot of this, but I always like to set the bar high, that addiction is a chronic illness. And like other chronic illnesses, it has times in a person's life that it is under better control, and it has times in a person's life that it is under worse control, in the same way that we see with diabetes, hypertension, and other medical chronic illnesses. Also similar to other mental health illnesses. So people can have multiple major depressive episodes and that kind of influences how we treat them and what sort of follow-up we provide them on that longer term, meaning, years and decades basis. So because it's a chronic disease, we can identify sort of where there is some dysfunction in the brain, and we can actually see where the brain is not at its full capacity, particularly on PET scans. We can see that in the amount of glucose and where that glucose is being utilized by the brain. So here's just a comparison of recurrence rates in substance use compared to other chronic illnesses. And you can see that these confidence intervals virtually all overlap with substance use disorders. We put a lot of effort and impact and time and energy into managing type 2 diabetes in our primary care clinics and in other care situations. We have a lot of resources diverted to diabetes related to pregnancy. We screen for it, and we do all of that because we know that if the pregnant person has diabetes during pregnancy and it is not under good control, that has potential negative outcomes on the pregnancy itself, on that pregnant person's health, as well as on that baby's health. And so we're screening for it because we know there are risks to that developing embryo and fetus because of the dyscrasias that occur in blood sugar with gestational diabetes. That is the same logic, right? We can just apply all of what I just said and substitute, diabetes and, blood sugars out for terms used in substance use, right? So we can call it a substance use disorder, an opioid use disorder, and talk about the potential effects of, opioid use on that pregnancy. So it really is, they really are comparable, and that is part of why the U.S. Preventive Services Task Forces does recommend screening during pregnancy. I'm sure we're all here because we are trying to address this exact slide, right? We're trying to figure out how can we integrate more substance use treatment into the work that we do, and how can we close this gap so that more people receive care. So I always talk a little bit about stigma because we encounter it so much. And when we work with pregnant people, I think it can sometimes take on a character of its own. And we really want to be careful in terms of identifying where that stigma is. It happens not only in that provider-patient relationship and that therapy-patient relationship, it happens to these patients in terms of their community relationships. If I had $1 for every time I said to a patient, so you've probably already beaten yourself up because they used, whatever during their pregnancy. Is there anything I could say that could beat you up more or make you feel worse about it? And the answer is universally no. And so my response is, so let's turn the conversation and talk about what can we do so that we can prevent that use from happening? What can we do to better support you? Clearly what I'm doing isn't isn't the right dose of treatment, right? Isn't the right therapy for you, isn't the right medical therapy for you. I don't blame my social worker. Please don't tell Erin, or I might really get in trouble. Right. So how do we work to uplift that person, rather than letting our stigma and how we perceive them impact them, but also trying to give them a little bit of support around the stigma that they're putting on themselves, the stigma that maybe family members are putting on them, or other folks in the broader community, and then of course the stigma inside of the healthcare system. Nancy and I work clinically together with a therapist. And one of the other things that we've done a lot of working on is addressing stigma in the hospital, and addressing stigma by other healthcare providers. So one of our big focuses when we talk about stigmas is the words that we use. And I encourage you to think about that as you look at that whole continuum of prenatal and postnatal care for your patients. So we have to kind of work on the culture in our hospitals, the culture in our outpatient clinics, to make sure that people with a substance use disorder, persons who are living with addiction, are treated in a kind and compassionate manner. So the other thing that I really like to point out, that oftentimes people are, assume good intent, right? Like people are trying to do the right thing. And so when the patient says to them, I'm an addict, they say, you're an addict. And then the next patient that comes in, they say, so you're an addict, because now they've learned that that's the vernacular. But when we look at this, this smaller study, but when we look at this study, most patients actually prefer, even when they use the term addict to identify themselves, they still prefer we use the term person who uses drugs. So I like to point that out, because I think people have really good intentions, and often with perinatal substance use, we've got a whole labor and delivery force to reckon with, right? And so making sure that they know the safe words, so we can create safer spaces. And going back to Nancy's lecture from last month, labor and delivery itself is a traumatizing experience and is high risk for it. It is a high risk time period or event in people's life. So we want to make sure that we equip our staff to kind of understand how trauma may have affected our patients in the past, and the words that we use to help create those safer spaces for them. These are some other terms that we want to avoid, and then terms that we prefer. The other one that I often like to point out is the clean versus dirty. There is no dirty test. We have, a positive test or a negative test, or an expected or an unexpected result. Again, Nancy and I have experienced it many times in our clinic, where somebody comes in and says, you're going to be so proud of me because my urine's going to be clean. I mean, I know you don't say that, but that's what it's going to be. And I'm like, well, you heard me say that we aren't going to call it dirty. So that's a step in the right direction. But I sort of look at that in the same way as I look at, those requests to use persons who use drugs, or other, less stigmatizing words there, and restate it, and respond to them and say, awesome, I'm so excited that you're only going to be positive for the buprenorphine today. That's wonderful. And so we just kind of rephrase it and parrot it back, in using hopefully those non-stigmatizing words. This is a slide just about that screening and assessment. Again, the U.S. Preventative Services Task Force does recommend that all pregnant women should be screened for substance use and substance use disorder using a validated instrument. Over at Corewell Health, we do screen at the initial, which is where the Great Moms program is located. We do screen universally for all pregnant people throughout the system at that initial prenatal visit. We've also worked with the Kent County Health Department to ensure that as many of the private practices and the other healthcare systems like Trinity Health and in University of Michigan West are also using validated screening tools to ensure that there is equitable care across the board for our pregnant people. So let's talk about antenatal opioid use. So I'm just going to pause to point out that when we're talking about studies, because many of them use gendered pronouns, you'll see gendered pronouns. I try to use the more neutral terminology of pregnant people when able and when appropriate. So antenatal opioid use increased just over fivefold from 2000 to 2009, and then 131% from 2010 to 2017 when looked at delivery. So we do see that this is more prevalent than I think people have realized in the past. And with a significant number of those individuals reporting misuse of opioids, even when prescribed. I just had a patient yesterday where, I asked the open-ended question of, so how are you taking your buprenorphine? Their trade name Suboxone, but how are you taking your buprenorphine? And she described taking it 3 times a day. And in my notes, I had she was taking it twice a day. In the prescription, I had she was taking it twice a day. And she was regularly forgetting that middle of the day dose, because who wouldn't? I would too. And so we had that conversation about, when she's taking the medication and how she's taking it. Technically, that's opioid misuse, right? Because she wasn't taking it as I was documenting it and as I was prescribing it. So, but rather than saying, you're doing it wrong, I said, well, let's see how we can maybe change this so that you don't forget the dose and that therefore you feel a little bit better. But identifying that opioid misuse can sometimes, not necessarily have to be that sort of, oh, they're doing something wrong. It could be unintentional on a patient's part. Along with that rise in opioid prenatal exposure, we have seen a concurrent rise in neonatal abstinence syndrome and the more specific neonatal opioid withdrawal syndrome. Here is the Michigan data that we have. I have not seen updated data beyond 2014, but there was a recent report that came out to 2019 still identifying substance use as a driving cause of maternal mortality after the 4th trimester, so in that first year of life between months 4 and 12. So we know that it doesn't end with the delivery as well, and that our families need support at least through that first year of life. Of course, the data just trickles off after that first year, so unfortunately we're not able to capture beyond that, but that is one of the reasons why partnering with programs like Nurse Family Partnership, where it's available, or maternal infant health programs in every county in Michigan can be very powerful for these families. It provides a little bit of extra support, a little bit of screening for that baby, a little bit of support for the parents, and goes through the first 18 months of life. So here's just an overview of the change of the change in rates in terms of in terms of the neonatal abstinence syndrome, rates here, and then the change in rates. You can see that Michigan has not been left unaffected. And this bottom one is the percent change in maternal opioid related diagnoses. So again, Michigan has not been unaffected. We are pretty close to the national average in terms of those averages, but certainly room to support our families even more. Again, a little bit older data. I just haven't seen newer data come out yet. If I'm missing something and somebody has newer data, I would be so excited to see it. But there are about 32,000 babies were born with NAS in the United States in 2014. So it is not an insignificant number, meaning that every 15 minutes, a baby is born that receives a diagnosis of neonatal opioid withdrawal syndrome. Pregnancy complications that can occur with opioid use. We can have a lack of prenatal care. It's fascinating because when we looked at our internal data within our system, we found that when somebody was sent to 2 different locations, so they were sent to the addiction clinic and they were sent to the OB clinic separately, that patients would regularly make their addiction clinic appointment, but they would not make their OB care appointment. And after kind of talking to patients about this and encouraging them to go to their OB appointments, it was pretty clear that we were asking a lot of our patients, and we were being very healthcare centric, right? When we dived a little deeper into that data, we saw that, we could be asking somebody to go to a lab. We could be asking somebody to go to an ultrasound. We could be asking somebody to go to a prenatal care appointment and to the addiction care appointment. And if they had any other thing that came up, because, pregnant people often have these other things called young children that maybe need like a well child care visit, that we were just asking them to go to so many different locations and do so many different things that it was just not really practical for a person to do all of the things. So as much as people can explore the opportunity of integrating this care into obstetric care, and reducing the number of kind of variables that a person may need to go to, that can be helpful. I'm sure folks read over some of the pregnancy-related complications, but certainly does increase the risk of very significant pregnancy complications. I used to be able to say that since we started people on MOUD, we hadn't had an abrupto placenta, but we did earlier this year, so I can no longer say that, but we do know that being on medication for an opioid use disorder and not using illicit substances where we don't know kind of what is the makeup of that substance does reduce some of the does reduce these negative outcomes. So this again is looking at chronic untreated addiction. So when we look at treating addiction, we reduce the risk of those negative outcomes by putting people on medication for an opioid use disorder. We are going to talk in the future about about co-occurring throughout in the series about co-occurring mental health conditions, but certainly we don't want to forget that many people with a substance use disorder have a co-occurring mental health concern. And then the other thing that I'm regularly pointing out to many patients is I'm actually more concerned about their nicotine use or their tobacco use than I am about their medication for an opioid use disorder. We also do a lot of education for hospital-based practices around the fact that when a baby is diagnosed with neonatal abstinence syndrome within the first 24 hours for a patient who is on medication for an opioid use disorder that has that longer half-life, it's actually more likely to be nicotine and tobacco related than it is my medication related, buprenorphine or methadone related. And that's often a strong teaching point for our collaborators. So maternal opioid use has been shown to be neurotoxic to the embryo. The caveat that we put on this is that the effects are definitely more severe with shorter acting opioids, and that we don't seem to see the we don't seem to see the neurotoxic effects up to age 10 for babies born to pregnant people that are on either methadone or buprenorphine. Again, the biggest thing is that after birth, babies need to be monitored for neonatal opioid withdrawal syndrome. Most organizations monitor for about 5 days. So neonatal opioid withdrawal syndrome is specific to opioid use, and we see it as a pretty significant percentage of babies that will be diagnosed. As we as a state and otherwise have started to transition more to eat, sleep, console, we are seeing that this number is decreasing. So Eat, Sleep, Console versus Finnegan scores look at baby's functional status. And so we're looking with Eat, Sleep, Console to see if baby can appropriately eat for a newborn. So we're looking at milliliters or time on the breast. And then if they can sleep their newborns for like an hour at a time, right? And if when they cry, they can be consoled within 10 to 15 minutes. So not that we're expecting babies not to cry at all, but that they're able to, the autonomic dysfunction is not such that it can't be consoled by parents. We all have had the experience where the baby cries, whether it's socially or at the hospital with our patients, and what does everyone do? Everyone hands the baby back to mama, right? Because that is the person that the baby was inside of. And that is the person that the baby calms down to, sort of the best and the easiest. I always like to point out to my non-pregnant patient, my non-pregnant parent or support person that if you've been around during that pregnancy, the baby actually does recognize your voice. And we know this because at 2 weeks, when babies have neck control, babies will actually turn toward a familiar voice and not towards an unfamiliar voice. So babies do recognize those folks around them as well. You know, so we also see that there is a lot of that there is a cost savings if babies are not noted if you have opioid withdrawal. Again, this is the transition switch between Finnegan's and Eat, Sleep, Console is leading to a decreased rate of diagnosis of neonatal abstinence syndrome, in large part because in Eat, Sleep, Console, we're really pivoting that treatment to be family-centered and away from being healthcare centered. So more, if you learn nothing else today, if everything else is review for you, or if you don't take anything else away, I hope you will look at how we can convert or move our systems in a direction that is more patient-centered and away from system-centered. We do see that neonatal opioid withdrawal, whether utilizing Finnegan or Eat, Sleep, Console, is less severe with buprenorphine than methadone, although we want healthy parents, healthy baby. We want that pregnant person on the right medication for them. It's also notable that the dose of medication is not related to the baby's risk of withdrawal. So we want to just make sure that babies get the treatment that they need. Just gonna do a quick time check on myself. Oh, I'm racing. I'm so I can slow down. That, or we'll have extra time for questions. So get those questions coming. I'm not looking at the chat. So if there's something in the chat, I know Joanna's usually on top of it and will let me know if there's something there. But also, please feel free to interrupt me. I know we're a bigger group, but hey, we can still make it work.
Dr. Poland, we do have a question in the chat from earlier. Do you want me to go ahead and ask that now?
Perfect.
Okay, so this question is, what are the validated screening tools that you use at your initial appointments?
So you can use, so the U.S. Preventative Services Task Force does not specifically recommend a single screening tool. So I can share with the MOC team, and then when we send out the PDF of the slides, I can share a study that was done that looks at the pros and cons of all of the different screening tools. Over at Corewell Health, we use the 5P screening tool. However, I will note that that is not actually the one that is most effective, but it was built in, and we went with it because something at that point was perfection versus what we could get in terms of a validated screening tool. So I'll send that document over. If I forget, remind me, but I wrote down screening study on my paper here. So hopefully I know what that chicken scratch means when I review my workflow for today.
Great, thank you.
Awesome. Great question. Keep them coming. I still find it hard with Zoom, what are we 3 years later, with knowing if I'm hitting the target for an audience or not. So, the more questions or the more feedback we get, the better I'm able to know if I'm going in a useful direction, because I don't want to waste anyone's time. So with the neonatal opioid withdrawal, let's look at treatment of that child. So we want to start with prevention. Everybody, I have this question come to me all the time from patients and from other providers. Should I just stop the medication? Should we just detox people and go to nothing? And unfortunately, that does not actually decrease neonatal withdrawal, because within 30 days, the vast majority, between 80 and 90% of individuals, will return to pre-treatment use, meaning they'll either go back and start using illicit opioids or be back on medications for an opioid use disorder. So we just want to make sure that people have the treatment that they need, because we'd rather have them on medication that we're prescribing than on an unknown substance. And because there's a lot of guilt and shame for many individuals who maybe return to illicit use in this case, they tend to be less likely to re-engage in therapy and treatment. And so we want to support that. We want to support the ongoing treatment. That said, if I have somebody who comes in and says, I want to taper, I am going to tell them this is the data, 80 to 90%, but I can't tell. I don't have a scale or a magic wand. I'm not a social worker, so I don't have I was not gifted a social work magic wand when I graduated. So I don't have a magic wand to be able to predict who is going to be successful with detoxing, who's going to be in that 10 to 20% that does do well with that. So what I tell my patients is, if you want to taper off of your MOUD, let's do it together. But I just want you to know that if it's not going as well as you want, and we need to pause a taper or even increase our medications or just take it off of the table entirely, that's okay too, because we want to, but what I want to do is walk this journey with you and support you however is best and most appropriate for you and your pregnancy. So that's sort of the approach I take. And I've had patients who have said, you know what, after hearing you and after thinking about it, and knowing that the dose doesn't matter in terms of baby's risk of withdrawal, that I don't think I actually want to taper. And I've had other patients who said, I really do still want to taper. And I will say, okay, then let's walk through that journey together. If somebody is also smoking or using vaping devices, if they have nicotine on board, if they have marijuana on board, which we know have negative outcomes for that baby and child during development up into the teenage and late adolescence, early adulthood, I'm going to tell them that I actually recommend we work on the smoking, the nicotine use and the marijuana use before we work on tapering off of opioids. If you want to know what is going to help reduce the risk of neonatal abstinence syndrome the most, that nicotine is the one to do it. If we want to reduce potential long-term outcomes in that baby's health, we want to reduce the marijuana and we want to reduce the nicotine. People are often really surprised to hear it, but it's also a way to sort of pivot the conversation to really reducing the risks that are associated with those longer term outcomes. So if the pregnant person continues on opioid therapy during their pregnancy, then baby is starting to show some signs of opioid withdrawal, in those first, again, 5 days of life is when we're screening for it. When patients ask me, like, why can't I go home with my baby? I just simply tell them that we don't want to put it on you to determine, is this normal behavior? Is my baby maybe getting a little colicky, or does my baby need to go back to the hospital? We don't want that to be our patient's responsibility. We don't want that. There's so much to think about and worry about when you have a newborn. We want to take this off the list. And then I sort of try to sell it. We do Eat, Sleep, Console, and I tell people you're going to get all the support and help in the hospital. And so hopefully it'll make those first few days a little bit easier. The other thing I love about keeping people for those 5 days is on day 5, when we go to discharge that baby, it's also the day of the baby blues, where everybody kind of has a bit of a hormonal crash because the placenta left. People have the baby blues. So this transient depression, anhedonia, lack of interest, so it gives us an opportunity to talk to patients about that, to let them know that it is normal to have that, to differentiate that from postpartum depression, to give them some resources. I'm sure Maria will talk about that in detail during her presentation, so I will leave it at that, but I like that we have them and can screen them on that. It can screen the pregnant person or the formerly pregnant person, the postpartum person, at that 5-day mark. We always want to encourage breastfeeding unless it's contraindicated for a different reason, because it does reduce that risk of both neonatal abstinence syndrome more broadly and neonatal opioid withdrawal syndrome. And then if the baby is still showing signs of physiological distress, we're going to pull in our pharmacological management. In most hospital systems, you'll find that when a baby goes to pharmacological management, that they do need some additional monitoring, and that baby may need to go to either a pediatric or unit, or even to the neonatal intensive care unit, depending on how your system is set up to monitor that baby. These are some of the additional non-pharmacological management tools that we can use. You'll probably notice that it's not that different to what you would do if any baby was showing a little bit of distress, and in terms of having kind of a quiet, calm room, feeding the baby, skin to skin contact, and those types of things. So there are no known long-term negative outcomes of neonatal opioid withdrawal. I think we probably should tell families this like 20 times a day when their baby's in the hospital, particularly if diagnosed with an amount of neonatal opioid withdrawal. The potential for cognitive deficits that were associated with opioid exposure in earlier studies was not actually statistically significant after controlling for tobacco use. So again, I know we're talking about opioids, but nicotine, tobacco, a lot of the studies are pre-vaping or look at tobacco, but I definitely transpose that to vaping as well, but any nicotine exposure when I talk to my patients. Again, there was a meta-analysis that looked at there was the potential for long-term neurocognitive and motor development delays, that when we controlled for other possible causes, we found that it wasn't actually related to their medication for opioid use disorder. It is crucial that we start treating, screening, and identifying opioid use disorders in pregnancy, so that we can improve the health and well-being of our communities. I have yet to meet a patient that doesn't, during their pregnancy, isn't kind of making different healthcare choices in order to possibly improve the outcomes for that unborn baby. So I think that it's kind of a universal. I know myself, you know, the thorn in my side is my Diet Coke. Anyone who knows me knows that is my drink of choice. That is my drug of choice. And when I was pregnant, I gave up Diet Coke. For like 8 years between trying to conceive, pregnancy, breastfeeding my 2 children. Man, it was hard. And I clearly went back. They're 9 and 11 now, so I'm back on the bandwagon of drinking Diet Coke. But every pregnant person makes some of those changes in their treatment, in their health and their lifestyle when they're pregnant, to try to improve those outcomes for that baby, whether it's diet, exercise, taking care of their chronic health conditions in a different way. We also see this with diabetes, where people are more aware of how they can better control their diabetes during pregnancy, when maybe they weren't doing as much of that when they were not pregnant. Methadone is not a treatment option available in many areas of Michigan, so it just might not be an opportunity, making buprenorphine the only option. I know most of you have probably already seen and heard the news that buprenorphine no longer requires that X waiver or that Data 2000 license or that Suboxone license. So buprenorphine can now be prescribed out of an office by any prescriber that has a DEA license. Because that announcement just came out in January, so some of our technology systems are still catching up. So I know my system still asks me to put in my DEA license, and I just type in "this is no longer required" by the DEA after it, and I haven't had any pushback. So some pharmacies are still saying, hey, our system is still requiring us to put this in, but it does seem to be getting less and less common from a practical standpoint. But legally, we do not need to have a specific waiver to our DEA license. We know there's a huge gap between the number of providers that provide treatment and the number of pregnant people who are looking for treatment. So medications for addiction treatment in pregnancy are recommended as the best practice of care for individuals with a substance use disorder. Pretty much every national and international organization recommends opioid agonist therapy. At this point, naltrexone has not been well studied during pregnancy, so it is not considered a first-line agent in pregnancy. All people who are pregnant should be provided with informed consent in terms of the risk of neonatal abstinence syndrome. Of course, if somebody has been on treatment, this may require a new discussion because of that change in their health status as well. And we should be prescribing and training individuals on naloxone use as well during pregnancy. We talked a lot about why not detoxification. So I'm going to skip over that bullet. I didn't realize it was repetitive here. I apologize. So what about naltrexone? One of the problems is we need detoxification or a period of abstinence to get onto it. And just for all comers, that's generally pretty difficult. It also becomes difficult because most detox facilities are not equipped to monitor a pregnant person in order to get to that 7 to 10 days without opioids. So it's hard to find a place to do this other than the general medical surgical hospital. It is also not associated with a decreased risk of overdose. If somebody is already on naltrexone, you can continue it, but remember that naltrexone is an opioid antagonist, so it blocks the effects of opioids. So at labor and delivery, we have to make sure that we switch them over to oral naltrexone at about 36 weeks, if not a little bit sooner, so that the injectable can wash out if that is what was being used, and it can make labor and delivery analgesia a little bit harder to manage. So definitely I consult with anesthesia and ensuring that anesthesia is aware that that person may be coming in if they deliver early or if they aren't off of it as long as we had hoped prior to labor, to make sure that they're well aware and we have a plan in place for that individual. So again, the recommendation is for methadone or buprenorphine as a standard of care. It has many maternal and fetal benefits, which are outlined here. And so we can see that we have a reduction in maternal mortality. We have a decrease in complications related to injection drug use, as well as increased engagement in treatment. So we see people getting more treatment and that includes both addiction treatment as well as prenatal care. And we reduce fetal stress on the fetal side of things. We reduce intrauterine growth restriction. We should still be monitoring for intrauterine growth restriction, but we are less, but we see a decrease in the risk for that. There, and we see a decrease in preterm delivery. So methadone and buprenorphine, if methadone and buprenorphine are both equally accessible, we know that buprenorphine has some safety. So all things created equal, buprenorphine has some safety reasons that we may want to lean on buprenorphine prior to methadone. I will note that most of the pregnancy-related statements from in terms of care are older, and so they were written when buprenorphine was still pretty new, and tend to say that methadone is preferred because we don't have as much data on buprenorphine, but the ACOG-ASAMS joint statement was written in 2012. So there's been 11 years worth of data that wasn't incorporated into that statement. Yes, there is discussion on the national level of updating that. There were some early studies that showed there was possibly improved retention with methadone. That has not been borne out as clearly as it seemed early on, but certainly methadone clinics do provide that higher level of service and that higher level of care that sometimes is appropriate. So when I'm talking to patients, it's about getting you on the right medication for your body and for your pregnancy, and that's kind of the driving force in terms of what medication to use. Buprenorphine naloxone has not been shown to have adverse maternal or neonatal outcomes But there are there are some folks that still prescribe buprenorphine monoproduct, and our product, and our product. In our clinic, we prescribe the dual product. Occasionally, I'll get somebody who comes to me and their previous prescriber has switched them over to buprenorphine monoproduct. And if they feel strongly that they want to continue it, I will continue it. But when I have that discussion with patients, oftentimes they would prefer to go back to what they were taking previously. So we can do the dual product in pregnancy with no untoward outcomes. In labor and delivery, patients may require higher dosing to provide adequate analgesia. What we have built into our program is not directive. It is, we recommend that they start with 1.5 to 2 times what they would prescribe to somebody who does not have buprenorphine or methadone on board, and titrate as appropriate to achieve adequate analgesia. And then we do a ton of talking about how important it is that after you deliver that baby, whether vaginal or cesarean section, I'm a proponent of safe deliveries, and I'm not an OB, so I don't know anything about vaginal versus cesarean section that's useful. We want you up and walking, because up and walking is what reduces pain the most. That's why, you know, post-operatively, it's a marker in the hospitals. How quickly do we get somebody up in a chair and up moving around? So we hit that hard prenatally as well, so that patients are expecting it. And I tell them, you're going to be exhausted. You're not going to feel like walking, whether you have a C-section or a vaginal delivery. You're not going to really feel like it, but I want you to get up and walking as soon as somebody comes in the room and offers it to you, because we want to make sure that we get the blood flowing, we get things moving, and we get some of those pain molecules and toxins kind of flushing through your system, so they're not just sitting there. And the best way to do that is with blood flow. So up and walk, up and walk, up and walk. So, you know, we do have an analgesia kind of recommendations available to folks through MOC and through the Great Moms program, if people are interested in seeing sort of what we do. This is the data from the state of Michigan through 2019 that looks at that those maternal deaths happening kind of within that postpartum period, and the majority of them happening in that 4 to 12 months postpartum, and kind of looking at what those overdoses also tend to increase as we get further along in that baby's first year of life, and certainly when people are on pharmacotherapy, that is lower than when they're not on pharmacotherapy. So
can you excuse me?
Sorry,
can you go back to the last slide about the different approaches to stay on Suboxone or off of it for the pain after delivery?
After delivery, we never want somebody to stop Suboxone. So they're going to continue it on the day of delivery, on the first day post-delivery. We don't want to stop buprenorphine.
Okay, great, thank you.
The reason is, if you stop buprenorphine completely and then put them on a full agonist, we have to get them into withdrawal in order to get them back on buprenorphine, and that's just no fun for anyone. Not us, but most certainly not our patients. So we tend to, so we recommend that people continue on the buprenorphine, and then add analgesia on top of that. Occasionally, if we're having difficulty controlling analgesia and somebody is on greater than 12 milligrams of buprenorphine, we recommend a reduction down to that 12 milligrams. But then we have to remember that we've reduced their baseline opioid exposure. So we're going to have to fill that gap, that opioid deficit, and then provide analgesia. So we'll still need to provide higher doses of opioids than we would in somebody who doesn't have that gap. So we can see that the leading cause of pregnancy associated but not related directly to the pregnancy, maternal mortality, is related to substance use disorders. So that is why this time period is a target for for us. And again, these pregnancy associated, not related directly to the pregnancy mortality, can occur during pregnancy or the 1 year period post pregnancy. And you can again see that the majority of those deaths, 68% of them, are in that 43 days or more postpartum, unfortunately. So this is part of why we recommend what I like to call piping hot handoffs, not just a warm handoff, for OBs who are transitioning patients after that 6-week postpartum visit. In our Great Moms program, we will actually keep people through as much as 1 year postpartum. And then should people wish to continue with our therapist actually goes into the family medicine residency program and can kind of make sure that that patient has their story continued and continues with her as a therapist as appropriate. So we want to maintain people on their medication throughout the postpartum period. Historically, there were people who would stop their medication in the postpartum period. So I'm going to speak a little bit specifically about the Great Moms program. We started at Corewell Health about 6.5. We're in our 7th year of providing care in our clinic. I mentioned that when we looked at our data, we noted that we were asking people to go to multiple places in a week, and that maybe we were being very healthcare centric. So we actually found that patients prioritize their MOUD visit and their ultrasound visit. They didn't want to feel sick if they didn't get their MOUD, and they were scared that if they went into withdrawal, that would their baby would feel that withdrawal. So they were trying not to distress their unborn child. And then they would prioritize their ultrasound visits, because I too wanted to see my baby when I was pregnant, right? So they would prioritize those two. That led to decreased prenatal care. They were marked as lacking prenatal care in the hospital. And then you can imagine that we provided a little bit of judgment and stigma towards those patients in the hospital-based setting, because we didn't see the whole picture, right? We saw the missed prenatal care visits, and we didn't necessarily see, kind of all the things we were asking people to do, and I guess the logical decisions that they were making, right? In terms of attending the MOUD visits, because we know that untreated opioid use disorder or missed medication, increases risk of the outcome of death. So we came together with the addiction medicine team and the maternal fetal medicine teams came together, and we started a program that integrated care. We wanted to make sure the system was patient friendly, provide as many of the services in one location as possible, and make sure that people had linkage to care on the outpatient side. So before us, we would, people would get discharged back to their PCP, they'd get lost in the transition. And now again, we see our patients up to a full year after the birth. And then I tell my patients, all I want you to know, because when they come and they first start seeing us, is when you're done being pregnant, there will never be a time that I'm like, here's your 30-day prescription, good luck. I want to make sure you make it to that next appointment. If, life happens and you have the appointment on, March 3rd, and then you have a sick kid or your car breaks down, we want to know about it, because we will refill that medication to a rescheduled appointment. I mean, within reason. Sometimes we have to have hard conversations with our patients where we're like, okay, we can't keep doing this, and we're fortunate that also at Corewell, there's a clinic that does walk-in hours, 5 days a week. And then of course, many program places also have ED-based medication starts. So those are, other opportunities for patients as well. So in 2022, we had 42 patients that enrolled and 43 babies, because we had twins. And you can see our average gestational age was 37 weeks. I should really put an asterisk there to note that we deliver all of our babies by 39 weeks. So that average has been inching up over the years for us. We had 5 of those 43 babies. So 12% were admitted for neonatal abstinence syndrome. Babies were admitted to the NICU for other reasons not related to NAS. So we capture that as well. According to ACOG, in a traditional OB office, about 40% of patients come for that 6-week postpartum follow-up. Ours is in the mid-70s, which is really exciting to me because there's a reason we ask people to come for that 6-week postpartum visit, and we really use that medication, that buprenorphine naloxone, as kind of the carrot for that appointment as well. So we've done also a lot of work with a hospital in order to make the hospital experience more person-centered, and in order to really increase the dialogue between the pediatric providers in the hospital, the OB providers in the hospital, and whether that's the prescribers, the doctors, the nurses, we've done education, including the clerks. We've done education in the MFM office where we're located, just to help people understand how to approach these folks and how to safely take care, to create safer environments for those individuals. And of course, all of that is predicated on trauma-informed practices, as Nancy discussed last month. So we are hoping that we are creating those support systems for our patients to assist with any barriers to care that they have, and engaging the birth parent as the leader in their recovery, and us as supporting actors and actresses in order to support them as well. So we've worked to really improve that antepartum experience, and we've made some iterative changes, with the general guiding light is that if we can keep the parent engaged in treatment and provide support through the first year, then hopefully we can set those families up for longer term success. So the things we covered broadly: screening for substance use and substance use disorders is universally recommended in pregnancy, and I will hopefully get that screening study to the MOC team today. And pregnant people should be referred to treatment or provided treatment in their generalist OB office. We want to make sure that people receive opioid agonist therapy and are not recommended detox, and that postpartum period is a high-risk period. So having gentle, kind handoffs when appropriate is what we hope to see. I end all of my talks to all the people who've lost their lives to addiction and those that try to prevent further loss. Losses, as many of you already know, my brother died of a self-inflicted gunshot due to his secondary to his depression related to his alcohol use disorder. And so I thank you all. Many of my pregnant patients are in that same age group as my brother was when he died. And I thank you all for being here and working toward a safer, healthier Michigan for the future generations to come. So thank you so much. I think we left a few moments for questions.
Thanks so much, Dr. Poland. Really appreciated that information. And we do have just a couple minutes left. We are coming close on time, but if there are any questions, please feel free to unmute yourself or put into the chat, and we'd be happy to answer them. And if there aren't any questions, then I did just want to thank everybody for joining us today. Thank you so much for being here of session 2 of 4 of our MOC MC3 perinatal mini-series. Your behavioral health consultant will be reaching out to you to follow up, let you know about our next session, and provide any slides that were presented and discussed today. And if there are any questions, I'll stay on for a couple minutes longer, but feel free to reach out to us if you have any further questions or need to get in contact about anything. Thanks so much for joining today.